My name is Lasse Rossvoll. I'm a physician and a PhD candidate from Norway and Ethiopia. And today I'm going to present to you this study called Scaling Up Treatment of Chronic Hepatitis B in Africa, 1-year results from a simplified treatment program, a public sector treatment program in Ethiopia. And this study was conducted as in a research consortium with collaboration between Norwegian and Ethiopian researchers called EthnoHep. And we have no conflict of interest to declare. So, simplified treatment guidelines, like the new WHO 2024 guidelines, are recommended in resource-limited settings. However, it is unclear how this simplified approach performs in real life, and it has never been studied before in Africa. So, we aim to address this knowledge gap by presenting 1-year results from a simplified treatment program in a large Ethiopian cohort. And in this study, we used treatment criteria that closely resemble the new WHO guidelines, offering a unique opportunity to address this, unique opportunity to see how this approach works in real life. So we established treatment clinics at 4 regional hospitals in Ethiopia, in Adama, Dupti, Jigjiga, and Jimma. HIV-negative adults with chronic hepatitis B were enrolled, and we applied simplified treatment criteria. As outlined in Table 1, the first criteria were clinical or radiological evidence of advanced chronic liver disease. Number 2 were APRI 0.65 or greater. Number 3 were ALT greater than 40 and HBV DNA greater than 2000. And number 4, HSE in a first-degree relative and HBV DNA more than 2000. And our primary endpoint were 1-year treatment outcomes, and the secondary endpoint were virological and biochemical treatment response. And we applied a Cox regression model to identify predictors of death. And since we considered decompensated cirrhosis as an intermediate for and also a predictor of mortality, we also applied a logistic regression model to explore the associating factors with decompensation. And here's the flow chart of our study. We included more than 6,000 patients with chronic hepatitis B in a 2-year time span. The median age was 30 years, and the sex distribution was quite equal, 50.9% male. And of these, 1,672 were eligible for treatment at baseline, and that's 28%. And 1,138 started treatment before July 2023 and were included in the present analysis. And we did this subset because to allow the patient at least 1 year of follow-up, and we also excluded those already on treatment before enrollment. So to the main outcomes at the bottom, 532 were active in care after 1 year, and that's 46.7%. 58 died, that's 5.1%, and alarmingly, 508 were lost to follow-up. That's almost 45%. And we applied a Cox regression model for mortality, and this is a busy slide, I know, so let me guide you straight to the main point. We're looking at the multivariable analysis. The variable selection in this model were based on existing knowledge on causal relationships and guided by a directed acyclic graph. And we found that in our best prediction model, 2 factors were included: age with an adjusted hazard ratio of 1.03 per 1-year increment, and also decompensated cirrhosis with an impressive hazard ratio of 8.74. And this slide shows a Kaplan-Meier plot comparing predicted survival in those with decompensated cirrhosis and those without. And as you can see, the difference is substantial. In the predicted 1-year mortality in those with decompensated cirrhosis was 26.4% compared to only 2.7% in those without decompensated cirrhosis. Maybe not too surprising, but it's still big numbers. And given that decompensated cirrhosis was considered an intermediate for and a strong predictor of death, we also applied this logistic regression model on decompensated cirrhosis, and we found that male sex, increasing age, high baseline HBV DNA, but also regular use of CHOT, you know, the recreational drug commonly used in East Africa. Those 4 factors were associated with decompensated cirrhosis in our model. So interestingly, this confirms the independent role of CHOT use in the development of advanced chronic liver disease, as previous studies have shown. And looking more closely on the loss to follow-up group, we found that there was a higher proportion loss to follow-up in the rural clinics compared to the more urban clinics. In Dupti, a rural clinic with a predominantly pastoralist population, 62% were lost to follow-up within the first year. And in Adama, in contrast, in Adama, a more urban site with, which is situated only about 100 kilometers from the capital, only 34% were lost to follow-up. And using the Cox model, we predicted, the predicted unmeasured mortality in the program loss group was 9.5%, and this was driven by an excess of patients with decompensated cirrhosis. And this slide shows the virological and biochemical treatment response in those active in care. The plot shows HBV DNA, ALT, ASD, and APRI on baseline and 1 year in those with paired measurements. And if you look at the HBV DNA, the decrease is substantial as expected on TDF therapy. And we found that 78% had virological suppression at 1 year. The median ALT decreased from 49 to 33, and the median APRI declined from 0.68 to 0.49. So conclude, based on the study I showed you, about half of the patients who initiated treatment were still active in care after 1 year, and the majority of them had virological and biochemical response to treatment. And I believe, if I'm optimistic, that this shows that it is feasible to scale up treatment in Africa using a simplified approach with existing infrastructure. However, there's a big however. The high proportion lost to follow-up underscores the need for better strategies and tools to improve the retention in care. We need more studies to identify the barriers and also to determine the strategies which is most effective. And I have many people to thank for this study. We thank the participants, the funders, the staff at the hepatitis clinics, and I'm also very thankful to my co-authors for their continuous support. And if you have any questions, here's my contact information, and I'm sure there will be time for more questions at the end. Thank you so much for your attention.